Hello, everyone. Welcome to the final installment of this May's Connecticut Connecting for Sexual Health series that's been co-sponsored by the Rattel STD HIV Prevention Training Center of New England and the Connecticut Department of Health, Division of STD Prevention. It is my delight today to introduce our final speaker, who's going to end us on a high note on biomedical STI prevention interventions, Dr. Amit Achhra, who is an assistant professor of medicine from the section of infectious diseases at the Yale School of Medicine. He's also one of our primary faculty members for the Rattel STD HIV Prevention Training Center for New England. And years ago, we got to know each other through a course that we run to train every infectious disease and adolescent medicine fellow in our region in terms of sexual health and STI management. That was only a few years ago. Fast forward to now, I'm delighted to say that we've been able to lure Dr. Achhra into the fold of more STI-oriented prevention and interventions, not just a focus on HIV. So, Dr. Achhra, please take it away.
Okay, well, thank you for the introduction, Kathy. And yeah, it's been a pleasure to have you as my mentor in the STI world. Okay, I hope you can all hear me well, and I will get going. Here we go. So no major conflict of interest because I will be mentioning some medical products, but it's not non-relevant COI to declare. And yeah, let's just, I like to do the conferences or talks with some case vignettes, some experiences to keep it interesting. And, I'll start off with this one here to set the scene. You have a 24-year-old man who have sex with men. So MSM is a term you would see I use a lot in my slides. So men who have sex with men who is now diagnosed and treated for syphilis. And he is asking, well, what can he do to prevent his future risk of syphilis and other STIs as well? And, if you think about it, we haven't had a lot of options for this kind of a situation till now, which is quite crazy to think. We have had HIV prevention, which I will talk about since about 10, 11 years now. But that's about it. Otherwise, there was nothing much, Okay, well, good luck. Use condoms. Don't have sex without condoms. But that's all you really had to offer. But things are changing. I think some of it you may have heard, you will hear about. And I think, we have a lot to offer for this kind of a situation now, even as compared to just 2-3 years ago. So I will, briefly discuss 3 topics, which are all under this big umbrella of biomedical prevention. It's certainly not exhaustive given the time limit. I will focus on a few issues here. So doxycycline post-exposure prophylaxis for bacterial STIs. I think you may have heard about it by now. We will touch briefly upon HIV PrEP. And I recognize not all of you are the specialized audience, so I will kind of focus more on some of the questions or myths sometimes I encounter in the primary care settings, for example, for HIV PrEP. And then I'll also touch upon what's happening in the vaccine world, which is also fascinating because we really hadn't talked about vaccines in the STI world for a long time. Okay. So doxycycline post-exposure prophylaxis. So let's just get into it. And I think my colleague here, Janine Dyer, is also mentioning how do you get the CME credits, by the way, in the chat box. And so if you have any questions, we can address at the end for that too. Okay, so doxycycline post-exposure prophylaxis. So I recognize this is a Connecticut audience or New England audience, and we're not actually that new to the concept. If you recall, we use this for a variety of settings. The good example, we are heading into summer now, is the tick-borne infections. And if you get a call that someone has a tick, which looks good for a possible tick infection risk, then you would give doxycycline post-exposure prophylaxis and hope that they would prevent Lyme and maybe more than Lyme disease. And we also do other settings like rabies vaccines for after a bite, for example, and so on. So the concept is similar here. If I can advance the slides, oops, here. So and it's actually funnily exactly also the same dose. So you have to take the single dose of 200 milligram of doxycycline after an unprotected sexual intercourse within 72 hours to prevent bacterial STI. So that's the concept when we are referring to doxypep. I think we have 100 milligram pills available most often. So often it ends up being 2 pills of 100 milligrams, but the dose is 200. And I will tell you some more details about what we know about doxycycline PEP as a concept so far and where it's heading, what are the concerns that I've heard about, what are some of the answers that we know, and so on. So there have been 3 large clinical trials, and I can show you the details of all these, but all 3 were done in a separate time and space, and all of them basically what they did was they took men who have sex with men or transgender women. Some of them were already with HIV, some of them are on HIV PrEP, and they were randomized to take this doxypep after having sexual intercourse within 72 hours or nothing. And they were followed with routine STI screenings as well as screening for any STI symptoms. And there were 3 different trials listed here. And strikingly, all 3 of them have shown very consistent results. So if you look at the syphilis, the numbers on the screen are relative risk reduction. So it anywhere from 73 to even up to 87% relative risk reduction in syphilis. Chlamydia, again, 70 to 88% risk reduction. Now for gonorrhea, we have seen a rather modest success, and in one trial here in France, they did not have any effect, and others at about 50%. So that is something we should know, that it's not very good for gonorrhea. And that's attributed likely to some of the doxycycline resistance that might be already prevalent in these regions. So it depends. You might have better success in your region depending on the prevalent doxycycline resistance. But for syphilis and chlamydia in particular, we had seen very high risk reduction. And I tell my trainees when I train here, like in medicine, that hey, this is exemplary. If you think about it, there's a lot of things we do in medicine and infectious disease where we nearly do not have as good evidence of having 3 different trials. It's quite a luxury, all answering the same question with same results, giving you very high certainty that this is probably a true finding. And all of these trials had anything from 12 to 14 months of follow-up. So, of course, the real world is not clinical trials. So the question had come that, well, what will happen in real world? Will it really lead to any community impact on the STI incidence? And so there are the 2 states that have been early adopters of this strategy, San Francisco and Washington State. And so San Francisco, California, they are reporting now what they are seeing after mass adoption and rollout of doxypep. And this is the real world experience. This is a high volume HIV PrEP clinic, which also had a lot of STIs, and about 40% of their cohort took up. Everyone was offered, and about 40% of them took up doxypep. And so if you compare their reported STI incidence before the implementation of doxypep and after, it went down sharply, and no effect on the groups who did not take doxypep. So very similar, but the group with high STIs before doxypep had a much lower number. It's not perfect, but again, similar efficacy in the real world that we have seen in the trials. So that's very reassuring. Same continuing on the same theme. So this is the data also presented recently at CROI of 3 large high volume San Francisco sexual health clinics and pre and post doxycycline implementation. So as you can probably tell, this was their usual STI chlamydia numbers and syphilis numbers. And from the time the doxycycline was rolled out as a post exposure, they were seeing a sharp decline in their rates. Now, of course, the United States is a very diverse country, and San Francisco is quite a unique place in the country. So we'll see what that means in other parts of the country. But as terms of its efficacy, I think it's looking pretty good so far. Okay. Obviously, the next question I encounter from everyone is, well, there must be some trade-off. I mean, that's the rule in medicine. There's no free lunch. There's no easy treatment for anything. We have to have some trade-off or some concern of harms. So what do we know about that? So first and foremost, the doxycycline drug itself had not caused any major adverse events in the 3 trials. Remember, this was not something they were taking every day. This was something they were taking as needed. And they did not see, for example, any severe esophagitis or severe sunburn or anything like that. But there were like 1 or 2 individuals in all 3 studies combined who had drug reaction, like a more sort of an allergy reaction, but that's also luckily not very common. The other major trade-off we do see here is that the gonorrhea, so the resistance to gonorrhea, if you look up on this study, the bar chart here, the red is the one which had a high level gonorrhea resistance. So in the arms which had no doxypep, it was about 12.5%. But in the doxypep arm, it went up, so more red here. So in other words, what we are seeing is that the gonorrhea that you do acquire while you are on doxypep is much more likely to be the one that's resistant to doxycycline. And that is a potential trade-off. But remember, we don't use doxycycline for gonorrhea treatment per se. And we also, also know that doxycycline is a class of its own. So it seems like so far that we're not burning other treatment options for gonorrhea or for anything else. So that's something we may have to take it as a sacrifice. We'll see. But that's the only single most important resistance concern that has come up. There have been smaller studies on things like Staph aureus and gut microbiome, but hasn't really shown any major signals so far, but these are early days, so we'll see. Remember also that doxycycline is not a big risk factor for causing C. diff, for example. So we think that the impact on gut microbiome, maybe it's not too bad, but again, these are early days to make a definitive statement on those. But I remind people that, like everything in medicine, this one too is a balancing act because, yes, you are maybe trading off with some more gonorrhea resistance to doxycycline. Yes, maybe there might be some more Staph aureus that you might acquire that is doxy resistant. But on the other hand, there is what you get is you're preventing syphilis. So you're using much less penicillin, which is a beta lactam. You're also using less ceftriaxone if you do get gonorrhea benefit. And you're also using a shorter course of doxy. Remember, in chlamydia, we're treating these days with 7 days of doxycycline. So you're using much less doxy as well. So, if the effect that we'll see, what will show in the community will be determined by how careful you are in implementing, right? So if you're choosing the right group of people, then you might be tipping more on the benefit side. By preventing the STIs, because remember, these people will require antibiotics at the end if they do get the STI. So, we'll see, the real world, how it looks, but so far, I think that's what we know. But of course, as I said in the slide before, that to get the most bang for buck, you've got to choose the right group of people so that you actually do not, you have a net benefit in the community. So this is a very interesting slide, which kind of tells you the story that this is from one cohort from Australia, but I think all our clinics, we can, anecdotally say that it holds true, that in this group of, men who have sex with men who are in the HIV prevention cohort, you'll see that about 25% were of the cohort was getting 75% of all the STIs. Okay, so in other words, this concept of frequent flyers, if you like. So really honing on these group of people would give you much bigger bang for buck, for example. So in the doxypep trials where we did see success, I will tell you what an average participant looked like. So average person was taking 5 doses in a month. They were reporting 3 to 5 condomless sex acts in a month. They were reporting 3 to 4 new partners in a month. And then they have had up to 2 bacterial STIs in the last 1 year. So that gives you a profile of a a person, I guess, who is most likely to benefit from doxycycline post-exposure prophylaxis. So, of course, the key would be to take a good history. And the most efficient prescribing strategies are based on STI history rather than, for example, HIV or PrEP use or anything else. Okay, so again, if we are clever and wise about implementing, I think we'll reap more benefits than harms. Other question I am getting often now as the awareness increases, because doxypep had been now covered in a lot of lay media as well. In New York Times, I think alone has like 5 articles on doxypep. Is what about cis women? Remember, we just heard from our colleagues in initial talks of this series about high rates of syphilis, for example, and congenital syphilis concerns and so on. So what do we know there? And also for heterosexual men who might also be, at risk of STIs. So the where we stand today is that there was only one clinical trial on the cis women, and that trial was done in Kenya on I think the commercial sex workers, where they did not see any benefit, but they analyzed their biological samples and concluded that many of these women were unable to actually take the prophylaxis, often because they were in circumstances where it was not possible for them to. There was some partner violence, some social dynamics which prevented them from taking. So it's kind of an inconclusive study in that sense that we don't know if it worked or not because they couldn't really take it. We don't have a study in the United States so far. We know that doxycycline probably have a good pharmacokinetic penetration in the genital tissues of cis women, so cervical penetration, etc. And we think that it probably will work if in a setting where people can take it, but we don't have those studies. And it reminds you again that STIs are as much a social problem as much as a medical issue here. Heterosexual men, it's an interesting question. So again, I am not aware of any definitive studies yet. Probably they're planned. One would think it's biologically plausible. If it works on the men who are sex with men, it probably should work on heterosexual men. Arguably, it might have even greater community-wide benefit because remember, these are also the men who are having sex with cis women. So perhaps the chlamydia benefit and syphilis benefit would have some onward benefit to women. So this is an open question. I would love to see what audience think. You can type your response in chat box, but should we wait for more studies in this group of people, which is technically a right answer, but also we are in the midst of an STI pandemic, and or should we just do it and then reverse the practice if we find out we were wrong? I don't think there's a right answer here, but as technically speaking, we need trials. So obviously the next question, people like to see guidelines. People need that kind of a confidence and permission, so to speak. So CDC has been thinking about this. The last I checked, the official guidelines are not yet fully published, but they had released the draft guidelines for comments, which we all reviewed and many of us commented on it. So I think the official version should be out soon. And basically it is recommending with one recommendation, which is like a very, very strong recommendation to do doxy prophylaxis, post-exposure prophylaxis in the settings which are for gay, bisexual, MSM, transgender women, the ones that we discussed, especially the ones who had a recent bacterial STI history. For other groups like cis women and cis heterosexual men, they have said they don't have enough evidence to make any recommendation. So we will see what the final version says, but this group will not get much help here. In the meanwhile, I think at some point with DPH folks, we will write something for the state itself. But right now, if you want to look up any guidelines, I think King County, Washington State, San Francisco, New York City, they are easy to search online, and they'll give you some directions about how to prescribe or who to choose. But generally speaking, I think the CDC will also probably release some official guidelines. And I have to say, in practice, we have started doing it. I have a few people myself who I'm prescribing. Yeah, we'll see how it goes. So, I mean, that was a summary on doxypep. I was looking up to see what the community is thinking, what people are thinking, and I talked to a lot of people in the patient population, and I mean the gay community who is telling me that they really want it. I mean, they are very excited. They feel empowered. So this is, for example, on a social media website, Reddit, where this person had a lot of response, and he was saying, my current GP, who is an MD, is sufficient, but he's not great. And he has prescribed me HIV PrEP, which is good. But when I'm asking him about doxypep, he's been reluctant. I feel like he might be judgmental. And when it comes to being honest about my sex life, I get the vibe from him that his solution to not getting an STI is to not have sex. And it's kind of reminiscent of what we heard about HIV prevention in the earlier days of HIV PrEP, and a lot of the data was there, the trials were there, but a lot of providers were very hesitant. Okay, so I think the question is, the community, I think, is ready. The data is there, but are you ready to prescribe? And that's what we need to hopefully make you ready if you're not already. Good. So that's doxypep. I will switch gears to some in the HIV prevention world. Okay, and then we'll address the comments or questions at the end. But feel free to type in the chat for me. All right, so switching gears. So this is a real case that I'm still following. So he's a 35-year-old man who presents to urgent care center for 3 times over the last 2 years for STI symptoms. And he's treated. At one point, he had even epididymitis, urethritis, and he was tested and treated. And he did say to me that he asked to be tested, quote unquote, for everything. He doesn't have great health literacy. He was told that, other than the STI, everything is fine. But he now presents to Yale with weight loss, aggressive skin lymphoma, and he has HIV with CD4 of 20, suggesting that he's probably been having HIV for a long time, potentially, and a very high viral load. And so we were able to actually get all the records of his previous urgent care visits in the state. There were different urgent cares in different parts of the state. And none of them, it seemed like, and had tested for HIV. And also he was unaware of PrEP. And also, interestingly, they had not tested him for syphilis. And, so this is kind of a recurring theme, and I, wanted to bring it up to see. So what I did, actually, I wrote about this on one of my social media accounts, what used to be called Twitter, is now X, to see what people think, because I wanted to hear the other side. And it's very interesting. A lot of ED physicians, a lot of urgent care providers came up and responded, and they said that, well, it's easy for you to tell us what to do, but in real life, it's hard. For example, many of the urgent care centers didn't have access to blood testing. So it would mean that, the STI testing could be done on a urine, but they would have to send them somewhere else to get the bloods. And many people would not just go to the blood section or blood part of the blood collection part of the testing. A lot of ED providers said that they are just too busy and getting too much brunt to do primary care, because this should be a primary care's job. But like, this gentleman doesn't have a primary care. So I feel it, I really do start to feel that this is not easy. But I think, given the broader benefit of not just the patient, but public health, I still would think that at some way we'll have to test them if we have the opportunity to test them. And so a lot of advocacy work has gone into it, but I hope you're all aware by now that in Connecticut, also the laws are not changing. So there is a recent bill, and I thank Arlene Lewis here, who shared the PDF, which can be accessed on the link below. It's like 3 pages, not too much to read. But basically, it tells you that requires physicians, PAs, APRNs, when treating anyone aged 13 or older in the hospital ED or primary care setting, to offer the HIV test, at least annually where practicable. The requirement does not apply, of course, if they are being treated for some life-threatening emergency, or if they already had an HIV test, or they lack the capacity to provide general consent or declines the test. But outside of this, I think, and I don't know, we'll see the real world. implementation, but even at Yale, as soon as this was implemented, I think within 2 or 3 months, we had like 7 or 8 new diagnoses picked up who were referred to our clinic. These people were, would have not been tested otherwise. So please do know that. And, I feel it's hard in real life. I feel for it, but I think just the broader public health benefit also makes an argument that perhaps we should take that extra step for HIV testing. And that hopefully then leads us to the HIV prevention. And, the HIV PrEP, of course, is a big talk of its own. So I won't, teach you everything about HIV PrEP, but I would just hopefully remove some barriers, some nuts and bolts, and then hopefully you're empowered to do it if you're not already doing it. And I'll show you some resources as well. So vocab here. So I think hopefully you all know by now there are 3 HIV PrEP options available. So one is the tenofovir disoproxil fumarate with emtricitabine. So in short, we will refer to it as TDF-FTC, the Truvada as a brand name, although that's available generic as well now. And then tenofovir alafenamide with the same compound FTC, and that's TAF-FTC or Descovy. And then the cabotegravir is a new kid on the block here, Apritude, and it's an injection. And this was approved at end of 2021. So if you think about it, we've been having PrEP for over 10 plus years, and I'll show you our report card on how we have done. So hold your breath. So yes, so if I refer to TDF-FTC, I'm referring to the Truvada, the oldest one, and then Descovy, and I'll tell you how to choose or which one is better or worse. So the first question here, again, I know I don't have time to poll you guys, so just read it, go walk through it, and make an answer in your mind and see where we landed. Who gets to get the PrEP? Okay, so any adult or adolescent who asks for it, or only those who provide sexual history of condomless sex with multiple partners, only those who have had a recent STI, or only those with sexual risk for HIV, but say not with anything else like injecting drug use. Make up an answer in your mind, take a second. And the answer is actually anyone, simply anyone. The point of this here is that our threshold to prescribe PrEP has changed. So it used to be that you have to have a sexual history, you have to have STI history and so on. But I think what we have learned is 2 things. One is that it's very, very safe, which I will hope to emphasize on you soon. And then also sexual history is often not forthcoming. So for example, if there's not been a rapport between the doctor or provider and the patient or a person, then they might not disclose their sexual history to you. But if they're asking for PrEP, you give PrEP, even if they're not yet ready to tell you why they are asking. So that's the point. And so CDC's language has changed. It says inform all sexually active adults and adolescents for PrEP. Providers should offer PrEP to anyone who asks for it. That's it, including sexually active adults who do not report behaviors that put them at risk for getting HIV. And the emphasis here is because the subjective reporting might not be perfect, and we shouldn't just wait for them to report before you offer them PrEP. So yeah, inform everyone, but prescribe anyone who asks for it, and ideally in the same day if while you have the opportunity to prescribe. But that doesn't take away the fact that we should be doing a better job at identifying those who are at the higher risk by taking a good sexual history. Remember, the people who are most likely to benefit are, someone who had an anal or vaginal sex in the past 6 months with either HIV positive sexual partner, or they've had bacterial STIs in past 6 months, or have a history of inconsistent or no condom use. And also remember, people who inject drugs could benefit from PrEP for HIV acquisition via injecting drug use, but also via sexual risk. So remember, do not exclude that group either. So brief targeted sexual history should be the part of routine history taking. CDC clinicians supplement is available. So if you have to go through, some of the previous talks went through some of this, but This PDF here will tell you, for example, the language you can use if you are hesitant to take good sexual history. Gives you some statements, sentences, and language you can use to break the ice and take some sexual history, which is targeted for PrEP. Good. And so how are we doing for PrEP? I think this is a reminder that we still get about 36,000 or so new HIV diagnoses. And this is a bit outdated, but the general number has stayed the same, plus minus a couple thousand. Majority are still among gay bisexual men, but 23% are heterosexuals and 7% injecting drug use. In Connecticut, we have generally seen a decline along with what we see in the rest of the nation. So that's good, but we still get about 200, 250 odd new cases per year. And who are these people? So again, anyone can acquire, but the groups who are getting the highest rates, and these are the groups you would target for PrEP even more so, are Black or African American, MSM, Hispanic, Latino, MSM, and then white MSM. But remember, the fourth group here is the Black African women. And I will show you soon that this group, for example, has very little HIV PrEP uptake as opposed to, say, white MSM here. So keep those in mind. And I show the slides to my trainees, and they really get shocked that if you look at the HIV prevalence in the United States in transgender women, we're looking at over 50% prevalence. I mean, if you look at someone between 30 and 50, we're looking at 50% risk of prevalence of HIV. That's higher than any highest prevalence you have heard in even sub-Saharan Africa. I mean, this is one of the highest HIV prevalence you could get in the world. If you look at someone who is an who's an American Indian, for example, transgender woman, with 64%, so more than 1 and 2% already HIV positive. So of course, if you do encounter a transgender woman who is sexually active, not HIV, you know what to do. You want to discuss PrEP with them. And this was a CDC advisory, basically suggesting that this is a high priority area. So how are we doing though? Well, I think unfortunately 10 plus years in PrEP, we're not doing as well as we should. So African American MSM, who have the highest lifetime HIV risk, have least PrEP coverage. And then white MSM have much higher PrEP coverage. And of course, the barriers are usual barriers in the United States healthcare system that we hear about: stigma, racism, access to healthcare, access to general primary care, access to prevention, cost, and also some barriers from providers, because if it's in specialized access, then that further reduces the chances that they would get PrEP. So keep in mind that we have a long way to go, and our Connecticut PrEP uptake numbers are also similar in terms of the communities that are left behind. Okay, next question I get: how effective it really is. Back in the day, people were following literature and they knew, but people have started to forget how effective really is PrEP. Make a guess in your mind if you don't know, and I'll reveal the answer next second. And I'm talking about sexual transmission with HIV. So it's very good. It's 99%. So imagine if we are not doing PrEP, how much we are missing out on. Now, it's not 100% also, though. That's important to know. You can have a breakthrough infection, but it's very, very good if there is a high adherence. So if the person is able to keep up over time, then its protection is over 99% for MSM and heterosexual men and women. A little bit less for people who inject drugs, which is hard to know if it's due to adherence, but also remember that they can benefit from the sexual transmission prevention as well. It's not 100%, but very high, very high. Okay. The other question I get from primary care is that, is it safe? We hear a lot about, especially in the Truvada, the TDF FTC, about kidneys and bones. And I think what over time we have done is we have ended up unintentionally overblowing the risk, and people get too afraid sometimes. So the cohorts that we have seen now over time is telling us that, especially with someone with otherwise healthy kidneys and young age, they have, very little risk of any lasting damage. If anything, they would have slight creatinine elevation, but it doesn't necessarily translate into permanent kidney damage. Very rarely you will see syndromes like Fanconi and tubular dysfunction, but that's very, very rare. And if you have someone who is older and have prior baseline kidney damage for other reasons, then that might be the group you might want to monitor more, and I'll show you the frequency of that. But otherwise, for a majority of young people, especially, it's exceptionally safe, and I think that the fear sometimes is a bit overblown here, and it becomes a barrier. We also hear about bone disease and osteoporosis risk, and again, same story. Yes, if you do their DEXA scans over time, you will see a slight decline in their bone bone mineral density, but it is like very small and it stabilizes. We have not seen, for example, these people getting more fractures or osteoporotic fractures. And also this is thought to be reversible if we stop. So again, unless someone has a very high risk of osteoporosis otherwise, for other risk factors, then you might want to be careful. But otherwise, as a blanket safety practice, you really don't have to worry for someone who is otherwise fairly healthy. So these two are the most common prep options that are still available. As I said, Truvada, Descovy, and often providers are asking, well, which one should I prescribe for daily prep? And this is the oldest one, 2012 approval. This is relatively new since 2019. And this pill is a bit smaller. This Truvada has been tested in not only MSM and trans women, but also heterosexual men and women and people who inject drugs. So much more data on this. This one has only been tested in MSM, the Descovy, and trans women has not been approved for example, cis women or people who inject drug. They're both equally effective. As I said to you before, for Truvada, there might be a small decrease in the EGFR and a bone mineral density. But on the other hand, there is also a small increase in LDL cholesterol in the Descovy. So again, we don't know what these small changes necessarily clinically mean. So it's hard to say. It's not quite simply to say this is like iPhone 6 and this is iPhone 15, so it must be better. It's not that. It's really a choice which you can make, and both are equally good options. And the side effects for both of them are actually quite rare. The one big difference here is that Truvada is generic. And so I think if, say, someone has no insurance, I think Mark Cuban's Cost Plus Pharmacy is selling it like less than 50 cents a pill with prescription, whereas the Descovy is not generic, so it's still fairly expensive. So keep that in mind. So the guidelines here basically say, well, you could basically choose any, and there is no clinically meaningful difference in adverse events. But if someone does have a significant kidney risk, then the Descovy is supposed to be better. It doesn't have the EGFR concern there. But that's one group you might want to consider Descovy more preferably. And then also people who have some previously documented osteoporosis or related bone disease, you might want to consider FTAF or Descovy. But otherwise, for most people, it doesn't give you any additional advantage over Truvada, but it's an option for people with these concerns. So the latest excitement has been about the injectable PrEP or cabotegravir. And in the clinical trials were done on men and women, cis women too, was shown to be actually performing better than the Truvada or oral PrEP. But that was because people were getting these shots more regularly. So the adherence was higher, whereas people were forgetting or not taking oral PrEP regularly. So difference was driven by adherence, but also not 100% effective, but also equally effective, 99% effective. And the way this is supposed to work is that you get your first shot, say today, the next shot in 4 weeks, and then subsequently you get the shots every 8 weeks. In the clinic, these are intramuscular shots. They have to be in the gluteals, therefore you see the butt cartoon there. It's not yet approved for thigh or arm injections, and you cannot self-inject. So you must come to the clinic, or RN or someone trained provider has to do the intramuscular injection. It's not subcutaneous, it's IM. So that's a bit of a barrier there. But otherwise, extremely safe. Some injection site reactions, I always find it interesting that a women cohort, for example, had much less concerns about pain in the injection site, where the men complain more. So you can guess why is that? I don't know. Uh, the headache was occasionally complained about, but generally speaking, very, very safe. Doesn't have a lot of GI complaints either because they're not taking it orally. And that's really about it. Otherwise, safety wise, it's considered very, very safe. Not much allergies either. It's not very common to get an allergy to this drug. Um, so, the pros are, of course, that adherence could be better, especially if it suits your lifestyle better. It's more discreet, so you're not carrying a pill with you. Um, we are not really concerned. If you notice, I did not even mention kidneys or LDL cholesterol because it doesn't affect them. So it doesn't matter. You can take it without concern for kidneys or bone. And so it's a great option, especially for those who just can't keep up with the oral pill. But of course, there are some cons. So this drug also forms the basis of antiretroviral treatment for HIV. So if you get resistance to this drug, uh, then it's even more concerning. Even Truvada is the antiretroviral, but this one is, you can say, a much more important drug for us to not sacrifice for someone who does get HIV. So there were a few people who acquired HIV when they were on this PrEP and started getting the resistance. There was this injection site reaction. There is a need for more frequent monitoring because they're coming to your clinic every 2 months. It's much more expensive, and it's much more intense for the clinic to keep up to the schedule, to the appointments, and the availability therefore is not very common. And I forgot to also mention here that for people who stopped injections, for example, they would have this drug in their system for a few more months, even at a lower level. So if you acquire HIV after that, you are at a risk of resistance unless you are protected by some other way. So that makes it a little bit complicated, and therefore I think it's still more restricted to the specialized centers because of these additional nuances on how to implement it. But I have had a situation here. So I had a 70-year-old man who was recently referred to our clinic to get the injectable PrEP by his PCP, because the PCP thought that it may not be safe for him to go on the tenofovir drugs, although he didn't really have any kidney disease. But as life is, he was referred in, I think, January, and by the time we saw him, it was April. And that was because he went on a cruise and had sex and was not using PrEP at all. Luckily, by the time he came to us, he was still HIV negative, and we were able to get him to PrEP. But that tells you that sometimes the best can be the enemy for good. Okay, so the best PrEP option is the one that's available to you and you can take regularly. So do not wait for someone to get the best shot and not give them an oral pill today. Remember, oral Truvada is so easily available that you shouldn't have to delay the other options and delay the PrEP for other options. And injectable PrEP, we certainly have it at Yale. I believe it's available at the Hartford and I think other major centers. I don't believe there is a direct list of clinics which is offering injectable PrEP, but that's something we can look into. But again, in the meanwhile, you don't have to wait for it to start. So a couple more slides on the PrEP here. Just another demythifying aspect I think I came across. So I have two cases now in my clinic. These were young men who the PCP did a great job of actually discussing PrEP. They presented to the PCP, they said they want PrEP. The PCP said, yeah, sure, we'll give you PrEP. And they did some baseline labs. And unfortunately, their baseline labs were showing some elevated alkaline phosphatase, some mild LFT changes. So the PCP decided, and these were mind you different PCP, different cases, but just two young people in a similar situation. Who decided to defer PrEP because they were worried about this whole safety of Truvada or PrEP for them while they were having these mild liver enzymes or ALP elevations. And then while waiting for this, both of these kids, they were both under 25, acquired HIV, and they presented to Yale for HIV care. So what went wrong here? Just think about for 1 second. Yeah, so I think what went wrong here is sometimes we have, sometimes, we say, well, what's the harm in testing? But, medicine is complex, and sometimes we over-test people or attribute wrong things to wrong because we tested it. And so I think, as I was emphasizing before, that what we have learned about PrEP is that it's exceptionally safe. So did this person really require baseline liver enzymes to begin with for PrEP per se? According to the guidelines, not really. And that's because we have learned that the PrEP luckily doesn't affect liver. And so having that knowledge is important, that you really don't need a lot of lab monitoring. So this is all you need. So for oral PrEP, you need a baseline creatinine. Then, of course, you need the HIV testing, the STI screening, the Hep B panel, because these drugs are also in the Hep B section, also in the Hep B treatment. And then HIV and STI screening at 6-monthly creatinine and 12-monthly creatinine. And there's a lipids if you're using the Descovy option, but that's about it. So, and then for injectable PrEP, even less so, not even creatinine, just HIV and STI, HIV and STI, HIV and STI. That's it. So no CBCs, no LFTs, no comprehensive profiles, and not even creatinine for this. So that's pretty remarkable. You don't really need. And know that liver toxicity is also not really a concern. It will be someone exceptionally rare. So both of these kids, for example, had other reasons. One of them had maybe fatty liver, other guy had maybe vitamin D deficiency affecting the ALK phos in some way. They have corrected since, but they are now with HIV. So keep that in mind. Another nuance that comes more in the injectable arm, which I didn't go into details about, is the need for checking HIV using HIV RNA. But I hope that's not a barrier to it. But certainly in the oral arm, that's, I think, in my opinion, is quite optional, and that should not be a barrier for giving PrEP. So to summarize, really any licensed provider can and should be doing PrEP. It shouldn't be restricted to ID or infectious disease. There are very good CDC guidelines for PrEP, which are excellent and free. Any individual should be offered PrEP if they're asking for it. And remember, we shouldn't forget women also, and people who inject drugs, are not just the gay men group. Very, very safe, very minimal safety monitoring. Periodic HIV and STI testing are probably two key, and then the Hep B and Hep C. But two key monitoring is really the HIV and STIs. And highly effective. Remember, the best option is the one that you are taking, and that's available to you. And as I said before, communities left behind here are people of color, the cis and trans women, and also people who inject drug. These are the people who are getting very little PrEP. In our very large PrEP cohort, for example, over 200 people, we barely have less than 10 cis women, even at Yale. So all of us need to do a better job in reaching those communities. Okay, final few slides before we chat. So what's happening in the vaccine world? So a reminder here that Mpox is still here. In case you're wondering how is that guy doing, it's been a while. No, it's still here, loud and clear. And in Connecticut, and these numbers might be changing already by April, we had 6 new cases this year alone. There were 4 in the entire last year. And I think by now there might be more than 6. This was the case of a guy who I recently saw in clinic. And I remind people that Mpox really had this endemic or going together with HIV. So of all United States, all Mpox cases in United States, 40 to 50% were people with HIV. So think about that for a second. Uncontrolled HIV and low CD4 count increase the risk of very severe disease, which is what you're seeing in this guy here on the right side, really eating away his hand. And the implications, of course, are that when we're thinking about Mpox, you really have to think about HIV in the same breath, test for it, and PrEP it if they are negative. And same story here, that this is group of people who are being considered for Mpox vaccine are the people who are also at very high risk for HIV, just by the demographics, and should be offered PrEP. So work we did here at Yale showed us that a majority of them were not on PrEP, were not with HIV and coming for Mpox vaccine or testing. So Mpox vaccination is important. There are 2 doses, and still there are groups of people who haven't got it. We think it's effective against severe disease. We'll learn more about the efficacy. You might still get reinfections, infections as a breakthrough infection, but we heard about those cases. It's not perfect, but I think it might protect against a severe disease. This is our Connecticut guidance. This is a group of people who we want you to target. So Genos vaccine is available. And the same website here also lists the sites which are, and this is a public facing website, so even patients can look up on where they can get the Mpox vaccine. And we certainly here at Yale also do it. You might have heard, if you pay attention to this field, that there was a lot of chit chat and excitement in the media about the vaccine for gonorrhea. So this was basically a meningitis B vaccine, which happens to share some antigens with gonorrhea, and it had shown some effect. But we recently learned that perhaps the effect doesn't sustain over time. So the recent update came that the efficacy, even though still showing some signal of benefit, if you see the curves are quite separate, but it's not perfect. So we don't have any recommendation about MenB vaccine in United States yet. United Kingdom, for example, has been more proactive on that. So we'll see how it plays out. But what I've seen is that this has really opened the field of gonorrhea vaccines. In fact, we were approached by a manufacturer, which I cannot reveal the name of, to do a gonorrhea vaccine trial. So I think this space is exciting, and we will probably get something in future, I hope. But right now, we don't have MenB recommendation just for gonorrhea per se. So final slides, biomedical prevention field is very exciting, but remember the equitable access will be important. We have learned from HIV PrEP, which has been now 10 plus years of availability, that we are still far, far from where we should be in terms of its uptake, especially for minority communities. There's a lot of provider anxiety we are seeing in the HIV PrEP era initially. A lot of people were not happy. My boss here tells me that we were proudly one of the first clinics to offer PrEP. Other people were thinking, well, are they encouraging more risky sex, or are they facilitating more STIs? And so there were a lot of anxiety about it. And I hope that doesn't become a barrier for other biomedical prevention options. And that would also feed into how the community trusts us in the healthcare if we are restricting things that are very effective for them. But we do need some good implementation science research to see what's the best way to increase the uptake, do it safely, choosing the right people, and increase the adherence to these prevention models, which is critical for their success as well. So going back to the very initial vignette, the guy who had recent syphilis, they come to you. I mean, there is plenty to offer other than just treating their syphilis. You are offering them HIV PrEP, you are offering them retesting, retreatment. You are also offering them, for someone with not syphilis, but say chlamydia or gonorrhea, an expedited partner therapy, which I have slides, but I don't think I'll have time to get into. Remember the doxypep we discussed, you could offer this guy, you could offer Mpox vaccine. Also remember substance use services, Hep B testing, Hep A vaccine, Hep B vaccine. So there's a whole piece of puzzle to really fit each other, so to really have a syndemic approach to preventing all of the above and not just one thing in silo. Many things to look out for: longer acting HIV prevention, more vaccines, also doxy PrEP maybe, so we'll see. That's also being studied. So that's it. So I want to acknowledge my colleagues. I want to also bring up important resource, which I have been mentioning in all of my introductions before, stdccn.org. So if you are in a provider who just need help with a case, please feel free to use this link. It's free. We are experts here waiting for you to send your cases, and we run it, we discuss it, we get back to you very quickly. And it's been a very successful program. Some states, for example, Massachusetts, are really more proactive in using it. I think our Connecticut providers are less aware. So I'm hoping this makes you more aware and make you use it. It's sponsored by CDC. It's also embedded in their treatment guideline apps. So please do use it, stdccn.org. So you're not alone if you are in trouble. I'd like to acknowledge my colleagues, Dr. Shu as well, who is here, and others also from DPH, Arlene, Anna, who have been instrumental for this series and this talk, and my mentors here at Yale, Dr. Barakat and Barada. Thank you. I will stop the share, but we can chat for a few minutes, hopefully.